Let's dive right into the diagnostic algorithm for restrictive and interstitial lung diseases. Our priority in this explainer is the exact next best step clinical logic you need for Step 2 CK. We'll systematically break down the restrictive split, walk through ILD evaluation, and then zero in on hypersensitivity pneumonitis and sarcoidosis. Starting with the restrictive lung disease split. So, when you're looking at PFTs, you identify a restrictive pattern when the forced vital capacity, or total lung capacity, is less than 80% of predicted. But here's the key. The FEV1 to FVC ratio stays preserved or even increases to greater than 70%. That right there is your branching point to rule out obstructive physiology. Once you've established restriction, you have to differentiate it using the DLCO, or diffusion capacity. A normal DLCO points outward to extrapulmonary restriction. Think morbid obesity, chest wall disease, or neuromuscular weakness. On the flip side, a low DLCO tells you the issue is intrapulmonary, meaning parenchymal interstitial restriction. Moving right into interstitial lung disease evaluation. Now, interstitial or parenchymal restriction usually presents with progressive exertional dyspnea and a dry cough. Your classic patient on the exam is typically an older adult, frequently with a heavy smoking history. The exam clues you want to hunt for are fine inspiratory Velcro crackles, which are highly sensitive, along with digital clubbing and hypoxemia that gets noticeably worse with exertion. Here's a major testing trap. An early chest X-ray in ILD can look completely normal. So if you suspect ILD, your next best step is to order a high-resolution CT. You're looking for high-yield findings like a usual interstitial pneumonia pattern. That means basilar and subpleural reticulation, traction bronchiectasis, and honeycombing. That HRCT helps nail down the specific etiology, so let's run through the big ones you'll see. Idiopathic pulmonary fibrosis requires management with antifibrotic therapy, pulmonary rehab, and oxygen if indicated. You'll also manage comorbidities like reflux and OSA and get them an early lung transplant referral if appropriate. Then you have your occupational exposures. Asbestosis causes lower lobe fibrosis and pleural plaques after shipyard or insulation work, which puts patients at risk for mesothelioma and bronchogenic carcinoma. Silicosis, that comes from mining or sandblasting, causes upper lobe nodules and definitely increases tuberculosis risk. Coal worker pneumoconiosis also causes upper lobe nodules and can lead to progressive massive fibrosis. Oh, and berylliosis mimics sarcoidosis with non-caseating granulomas. What about the alveolar filling mimics? Well, pulmonary alveolar proteinosis is caused by impaired macrophage clearance of surfactant. Look for crazy paving CT pattern and milky BAL. These patients might need whole lung lavage. Cryptogenic organizing pneumonia gives you subacute cough, fever, and patchy migratory infiltrates that are steroid responsive. And finally, eosinophilic pneumonia features pulmonary infiltrates with blood or BAL eosinophilia linked to asthma or drugs. Treat that by removing triggers and starting glucocorticoids.
Next up, hypersensitivity pneumonitis.
This is fundamentally an immune response to inhaled antigens. We're talking mold, bird proteins, farming exposures, or even contaminated water systems. It comes in two flavors. Acute disease hits you with recurrent, self-resolving fevers, chills, cough, dyspnea, fatigue, and leukocytosis shortly after exposure. Chronic disease is more insidious. You'll see progressive cough, dyspnea, fatigue, weight loss, a low DLCO, exertional hypoxemia, and reticular opacities on imaging. To secure the diagnosis, a bronchoalveolar lavage will show lymphocytosis, and a biopsy reveals lymphocytic inflammation with poorly formed non-caseating granulomas. But for your initial therapeutic reflex, it's always strict antigen removal first. If the disease is chronic or severe, then you step up to glucocorticoids and eventually evaluate for a lung transplant.
Let's shift gears to sarcoidosis.
The classic vignette here is a young adult, especially a Black woman, presenting with dyspnea on exertion and occasional fine rales, but notably no wheezing. Keep this key fact in your back pocket, though. Over 50% of these cases are discovered completely incidentally, and the patients are totally asymptomatic. You might also spot hepatosplenomegaly or asymptomatic LFD abnormalities. If they do have symptoms, your best initial imaging test is a chest X-ray. You're looking for that visual confirmation of a widened mediastinum with bilateral hilar lymphadenopathy and potentially some interstitial infiltrates. Because sarcoidosis is systemic, you have to stay hypervigilant for extrapulmonary manifestations. Neurologically, look for facial nerve palsy or central diabetes insipidus. Cardiovascularly, it can cause an AV block or restrictive cardiomyopathy.
Other high-yield exam clues include hypercalcemia, parotid gland swelling, and anterior or posterior uveitis.
And then there's erythema nodosum, which shows up as tender, indurated erythematous nodules right on the anterior legs. This is a massive clinical anchor. Because of its strong association with sarcoidosis, the initial next best step for a patient presenting with these nodules is actually a chest x-ray to check for that hilar lymphadenopathy.
For definitive diagnostic confirmation, you need a lymph node biopsy demonstrating non-caseating granulomas. When it comes to treatment, if there is symptomatic, you just observe. Glucocorticoids are strictly reserved for symptomatic pulmonary disease or organ-threatening extrapulmonary manifestations. Let's quickly recap the diagnostic pathway. Identify restriction on PFTs with an FVC under 80%. Check the DLCO. Normal means chest wall, low means lung parenchyma. Suspect ILD and immediately order a high-resolution CT to spot the fibrosis. Finally, confirm the specific etiology using their exposure history, a bronchoalveolar lavage, or a biopsy. That logic will seamlessly drive your targeted management.